Hello, my name is Douglas Totten. I am a third-year medical student at Vanderbilt University School of Medicine. Today we're going to talk a little bit about hearing and balance in older adults. First and foremost, it's important to remember that hearing and balance are intrinsically connected via both the anatomy of the vestibular and hearing portions of the organ, as well as the nerve itself, the vestibulocochlear nerve. Secondly, it's important to remember that both of these functions diminish over time, with up to 50% of people over the age of 75 having hearing loss, and around 3/4 of people over the age of 70 having a balance impairment of some form or another. Hearing is obviously important for many portions of life. Losing the ability to hear means the patient loses the ability to do quite a bit of what they were used to. This predisposes to cognitive decline, dementia, and falls, which then predisposes to a whole host of other medical concerns as well. From a social standpoint, workability is often reduced, if not eliminated, and patients often experience a lot of isolation and even depression as a result of not being able to communicate like they once were able to. While these studies are important and very helpful, it is often important to recognize that the vestibular dysfunction plays a role in falls as well, given the nature of the vestibular system and its effect on balance. How do these change with age? Well, we lose neurons and hair cells in both the cochlea as well as the semicircular canals, which play the main role in our balance. The other part of our balance organ, the otolithic organs, the utricle and saccule, can also have otoliths dislodged that go into the semicircular canals, causing benign paroxysmal positional vertigo. This is also shown to be increased in prevalence at higher ages. There's a decreased functional ability in the vestibular system as well as patients age. And lastly, though not as well studied as the other points on this slide, osteoporosis may affect the ossicles. This is highly debated and is mainly from a theoretical standpoint at this point, as bone remodeling theoretically could cause ossicular discontinuity. However, in practice, this has not yet been shown to be the case. However, more research is needed there. How can these issues be prevented? That is a great question, as these are multifactorial concerns, and in addition to being related to aging, very difficult to truly prevent. However, delaying is possible. One thing that is always important when it comes to hearing is to reduce loud noise exposure, as this can cause traumatic damage to the cochlea and nerve, and thus results in reduced hearing at a younger age and predispose hearing loss in the older population. Ototoxic medication should be avoided for similar reasons. Interestingly, antioxidants and caloric restriction have both been shown very recently to delay and/or prevent age-related hearing loss in some animal studies. More research will be needed here when it comes to humans, however. Lastly, ear infections can come both bacterial and viral etiologies, and can also predispose to sensorineural hearing loss. Fungal ear infections, I should mention, are much more rare. Here, we can see known ototoxic medications. Please do note that both aspirin and loop diuretics are ototoxic, though they are both used very commonly in the medical setting. How is hearing loss diagnosed? Well, this is a challenge. The USPSTF currently has an incomplete grade for evaluating asymptomatic adults for hearing loss. That's because there's not enough evidence yet to make a determination one way or the other. Meanwhile, the American Speech Language Hearing Association recommends hearing evaluations once every 10 years until the age of 50, and every 3 years after the age of 50, so long as the patient does not demonstrate hearing loss. Why is this data conflicting and incomplete? Well, The challenge here is that the few studies that have looked at this have not shown convincing evidence that these hearing tests have been worth it from a population health standpoint. However, a lot of asymptomatic adults actually do have hearing loss and simply do not recognize it. Sometimes their families do not either, as it is a very slow and subtle decline when it comes to presbycusis or age-related hearing loss. Thus, as a primary care provider, a medical student, nurse practitioner, or other individual on the front lines of medical care who may be caring for patients with unknown hearing loss, it is important to have a high index of suspicion, especially when hearing loss is very treatable. How is it treated? Well, first and foremost, audiology will likely be involved. From a general framework, one can consider sensory neural hearing loss as requiring a hearing aid, and conductive hearing loss as requiring a surgery to repair a disconnect in the middle ear. This is a very general framework, and there is a lot of nuance to this. However, for the purposes of this talk, this is sufficient. Other options include the hearing aid, as aforementioned. This is very helpful, non-invasive, and is often used in the older population. However, it can be expensive and often requires audiology follow-up. Secondly is the cochlear implant. This is obviously more invasive as it involves implanting an electrode into the cochlea itself via the round window. You can notice here a processor over the ear and a magnet that is then sending and transmitting the signal to the electrode into the cochlea, which then stimulates the hair cells, which then sends the electrical signal to the brain. This is not natural hearing and is much more effective in the high frequencies as opposed to the low frequencies, and should be used with caution in patients with residual frequency in the low frequencies. However, it is a very helpful device that has certainly helped many patients over the course of the years. Lastly is the bone-anchored hearing aid. This is helpful, and while it is invasive and requires an implantation into the skull, it sends a signal through the skull to the cochlea, taking advantage of the fact that the cochlea itself needs the signal from somewhere, but not necessarily the external and middle ear. Thus, this sound can be transmitted via the skull to the cochlea, thus bypassing the main portion of acoustic hearing. As far as balance goes, safety must be assessed before all else. This requires a fall risk and further assessment. After all, falls can be debilitating in the older population. Vestibular rehabilitation appears to be very helpful in some cases of vestibular dysfunction. However, high-quality evidence remains lacking due to the difficulty in testing this. Surgical implantable devices remain in development as well. In summary, hearing and balance worsen with age. These also have adverse effects on the quality of life. Those are the first important things that must be understood. After this, it's important to recognize that one must have a high suspicion for hearing and/or balance impairment in older adults, especially in primary visits where the patient may or may not be expecting to have a hearing problem, and their family may or may not know either. This is also helpful as there are very many options for hearing loss, the number one of which would most likely be a hearing aid for most patients. Balance is difficult to treat, however, rehabilitation may help, and in the future, there very well may be implants to help with this as well. That, however, goes in with the last bullet here, where more research is needed. Here are the references that were used to make this talk. Again, my name is Douglas Totten. You can find me at douglas.j.totten, that's Totten, at vanderbilt.edu. Please feel free to email me with any questions. Thank you very much for your time. Have a great day.